Welcome everyone to this month's KCQBIC Forum. We are very excited to have you here today, and we're talking about a very exciting topic, which is health literacy. So my name is Stacy Farr, and I am the co-director of the Healthcare Institute for Innovations and Quality. Excited to talk with you. I'm going to give you a high-level overview of the session before I kick it off to our amazing speakers. And then I guess just a little bit of housekeeping for anyone on the call. As the session goes on, we really love to keep this interactive. So put any comments or questions you have for any of the panelists in the chat. And then at the end of the session, we'll do some Q&A discussion and we'll refer to the chat. We'll also let people come off mute. But even during the session, we do love to have a little bit of conversation going on in the sidebar and get people really into the dialogue and discussing the topic. So with that, I will continue. So a little bit about HiIQ, or the Healthcare Institute for Innovations and Quality. So, we really have this vision of Kansas City delivering the highest value, most equitable healthcare in the nation. And, our mission then is to catalyze and facilitate multi-stakeholder collaborations so that we can improve the quality and value of healthcare in Kansas City. And we are supported in large part, with from our partners here with BioNexus KC, with UMKC Next Gen Precision Health, and also with KU Frontiers Clinical and Translational Science Institute. And so, as we kind of all know, we have health systems that are really struggling to figure out how to improve care. We know that right now we're operating in fee for service, where we're delivering a lot of volume-driven healthcare that costs a lot of money, and as we've seen in multiple landmark national reports, have questionable quality in some cases, especially compared with many other countries. And so we all know that we need to get to this value-driven healthcare where we can deliver higher value, higher quality care at a lower cost, so that we can really be value-driven. And, so these payment models that are tied to that by Medicare and some of the commercial payers are also moving toward value-driven healthcare. And what we're doing through HiIQ is really trying to create a regional strategy where we can bring these multiple stakeholders together, including providers, researchers, purchasers, payers, the community, and patients, to really think innovatively and kind of take on the changing healthcare landscape. Because we know that everyone's struggling to figure it out, and we can hopefully help each other create this regional strategy to do so. And so what we're really, kind of moving toward is, there's this learning healthcare system where all hospitals and units are learning healthcare systems, right? Where you get these learnings and then you incorporate them and iteratively improve over time. But what we're really trying to move to is a learning healthcare community where we expand and move out of our silos so that we can create a network of hospitals paired with those other stakeholder groups so that we can really learn from each other, share best practices, and disseminate those practices that are successful to other hospitals. And HiIQ has kind of three main pillars, three main legs we stand on to achieve kind of these goals. And so the first of which is regional quality improvement, where we work, this is a map of Kansas City, and we're currently working on projects 1 and 2, which are these, regional quality improvement projects across all of the stakeholders, where we are, working with clinical sites that are paired with the other stakeholder groups so that we can implement evidence into routine care, and then we can do mixed methods evaluations of those outcomes and try to make a really big impact on the health outcomes in our community. And so we're currently in projects 1 and 2, which is the opioid management project and transitions in care for heart failure. And then, in order to really do that kind of large scale quality improvement, we've recognized, that we need to really have training on how to do that. How do you change care, which is training and implementation, actionable research approaches, or TIARA, as we have cutely named it. But this is a training program for researchers, for healthcare workers, for anyone who really wants to kind of learn the basic science of how you change care, of how you implement evidence into care, into communities. And so we have offered that as a certificate program through Frontiers. We are currently offering it as coursework, graduate level coursework at the University of Missouri. It's brand new this fall. We're also offering this next year. Again, we'll be doing another certificate program. And so there's a lot of different opportunities and ways we're growing that implementation training. So do reach out if you have questions about that. And then our third arm is really dissemination and engagement, and kind of, we're all here today for that, right? So this is a way, we have the forum every month, and it's a way to bring the entire community of Kansas City and beyond. We've really reached a lot of, national speakers and national audiences as well. So it's a great way for us to talk about some of these big pressing healthcare topics in our region and figure out ways to work together, collaborate, and develop solutions. And so, as I had mentioned, we have our 2 regional projects, and I won't go into those in great detail, but we do have our opioid management project, which is engaging patients in care coordination. And this is a partnership that we are doing with ComCare and the Missouri Hospital Association through a primarily ED-based intervention where patients who present to the emergency department with opioid use disorder are connected to both medication, but also a peer recovery coach who can help them kind of navigate and connect to community treatment in ways that are other models have shown to be really evidence-based at getting people into recovery and staying in recovery. So we're currently helping implement and evaluate that program. Findings to come. And then we also are working on our Transitions of Care for Heart Failure project. And this one really is a suite of interventions that we offer and help hospitals with along the, we're calling this the heart failure carousel here, where we have, patients who have heart failure who, present to the emergency department with their heart failure. Depending on what is going on with them clinically, they're either admitted to the hospital or then prepared to go home. And then once they're home, trying to stay out of the hospital again. And so we have interventions that are at different points of the carousel. So we have 4 different interventions that we're supporting through there. And then to kind of wrap up, we, as I had mentioned, have our forums. Today, as you all know, is our health literacy. We have 2 more forums this year, Caregiving Trends, Burdens, and Breakthroughs next month. And then in November, we'll give an update on our Transitions of Care project. And everyone on here probably also received our survey. We're currently collecting information so that we can identify the topics for next year. So please do fill that out because you're important. Your feedback is really important to us. And so with that, here's our agenda for today's session. We have a lineup of really excellent speakers. And so I will now turn the floor over to Michelle Spatz, who is an outreach and engagement coordinator with the Network of National Library of Medicine, Region 5, and at the University of Washington. And so she'll be speaking from a health information and kind of library science perspective on advancing health equity through health literacy, some novel approaches. So Michelle, the floor is all yours.
Thank you so much, Stacy. It's such a pleasure to be here with your group today. I've always been passionate about health literacy throughout my career. I think it's essential if we're going to attain health equity. And as Stacy shared, I am a health sciences librarian, so I had to get the word novel into my program title. So during our time together, we're going to have a high-level overview of health literacy. For some of you, this may be a refresher. For some of you, you may be able to connect, with the points that I hope to make. We're going to talk about health literacy's connection to health equity, and then look at some novel approaches I've used to embed health literacy in clinical education and practice. So let's go ahead and get started here. So a multidimensional view of health literacy was incorporated into the federal government's Healthy People 2030 program, which, as you may know, every 10 years creates a blueprint to improve the nation's health. The current blueprint, Healthy People 2030, defines 2 types of health literacy. The first is personal health literacy, which is the ability to find, understand, and use resources that inform health-related decisions. The second is organizational health literacy, the degree to which organizations equitably enable individuals to find, understand, and use resources to inform health decisions. This includes healthcare facilities, policies, procedures, and staff communication, which may either enhance or impede health literacy. Health literacy is multidimensional. It crosses these many different domains. Print literacy, which is reading and writing, I think it's the one we're most familiar with. Numeracy, which encompasses math concepts, so things like risks and benefits, understanding medication dosages, understanding test results, blood pressure readings, nutrition labels, those kinds of things. Oral literacy, which is listening and speaking, being able to articulate our needs in a healthcare setting, or as a healthcare professional, being able to communicate health information in a way that is meaningful to patients and actionable. And then the last is digital literacy, the ability to access and apply digital health information and navigate the digital healthcare system. So an example would be being able to access and utilize in a meaningful way the patient portal. And to address and improve health literacy, we must address its many dimensions. Health literacy is also contextual. Things like illness, stress, fear, anxiety, or pain may impede our ability to process information or disrupt existing literacy skills. So too can demands in the healthcare system, such as unfamiliar environments, terminology, organizational expectations, or regulations. And this is true for anyone, regardless of their literacy level or educational attainment. And I always like to dispel this myth that low health literacy somehow means low intelligence. We are all capable of learning with the right supports. So why does this matter? The human costs of low health literacy are very well documented in the research literature in relation to poor health outcomes, some of which are outlined here. So things like not being able to manage a chronic illness, resulting perhaps in hospitalization, or taking too much or too little of a medication because we don't understand our treatment plan. Why focus on health literacy? According to current data, only 12% of US adults have proficient health literacy. So of every 100 US adults, 88 may lack or need help with health literacy skills. This is another way to visualize it. This map shows low health literacy in the United States by counties, and the yellow indicates the level of highest health literacy, and the dark blue, the lowest health literacy. And you can see by the map that it is a very pervasive problem. So this slide, which you may have seen before, illustrates the concepts of equality, equity, and justice, where equality is assuming that everyone benefits from the very same supports. Equity, it means giving everyone the supports that they need. And justice is where everyone benefits without supports or accommodations because systemic barriers have been removed. So yes, health literacy is foundational to health equity, but more importantly, it's essential to health justice. In our case, it's removing the barriers that prevent individuals from being informed and engaged in their health and well-being. In removing these barriers, we empower individuals to engage with their health. One of the reasons I was invited to talk with you today is because I worked with Pacific University's College of Health Professions to embed health literacy in an interprofessional capacity within their graduate health professions programs, as well as within the federally qualified health clinic that was co-located within the university. While there, I led a number of health literacy initiatives, and I'll let you decide which ones were truly novel. After arriving and meeting with the deans of the different health profession schools to discuss their approach to health literacy, I realized that in order to enable faculty to incorporate health literacy into their curriculum and to support interprofessional collaboration, we needed a one-stop place to find teaching resources to support busy faculty, as well as promote a common understanding of health literacy across the different health disciplines. So I created an online guide, the Health Literacy for Interprofessional Education e-Toolkit. You can see some of the content in the gray bars down the left-hand side of the screen, which are navigation points for the e-Toolkit. The content supports the 10 core interprofessional health literacy competencies based upon research by Dr. Cliff Coleman. He's very active in the health literacy field, so maybe you have heard of him or are familiar with his work. I presented the e-Toolkit at the monthly all faculty meeting and promoted it through an email blast to all faculty. I also offered 30-minute hands-on faculty workshops over lunch, which were well attended. And while this toolkit is still available online, I don't think it's currently being maintained. And Pat, do you want to go ahead and pop that toolkit URL into the chat box, please?
Yes, it's there.
Okay, thank you. Sorry. I gave student presentations on health literacy as a classroom guest lecturer, in addition to knowledge-based learning and interactive exercises. An important message centered on health literacy universal precautions, which are aimed at simplifying patient communication and confirming comprehension, so miscommunication is minimized, making the healthcare setting and system easier to navigate, and supporting patients' efforts to improve their health. Research shows that interventions for people with limited health literacy also benefit those with stronger health literacy skills. Universal precautions removes barriers to health literacy and thus promotes health equity. I always made sure our health profession students knew about the National Library of Medicine's consumer and patient health information resource called Medline Plus. This completely free, evidence-based, ad-free online resource has thousands of topics, including information on drugs, both prescription and over-the-counter medications, and herbal medications, and medical tests. The website is fully translated into Spanish, and the topical icons on the left can guide you to major sections. For instance, Health Topics has information on wellness and more than 1,000 diseases, illnesses, and health conditions. Information is presented in an easy-to-read format, and certain material is available in languages other than English and Spanish, and that's medlineplus.gov. The second resource is the free biomedical database called PubMed, also produced by the National Library of Medicine. It's the world's largest repository of biomedical literature and includes some links to full text content. It was important to share these two free resources, knowing that once the students' graduate education ended, they may find themselves in a clinical practice that doesn't have resources or maybe has just a few resources. These two items support both patient education and clinical practice. In collaboration with the director, the faculty, and student staff of the Pacific Psychology and Comprehensive Health Clinic, another project I embarked upon was an organizational health literacy assessment of the clinic. I conducted the assessment with the help of my capstone student using the first iteration of this guide by Dr. Rima Rudd, in my opinion, an icon in the field of health literacy, and her colleagues. This is now in its second edition. This guide is freely available online and provides tools to assess how your organization is meeting health literacy attributes. In another initiative, I co-led the annual Interprofessional Education Case Conference on health literacy. Students were assigned to interprofessional cohorts. After a faculty presentation on plain language and teach back to confirm patient understanding, we shared a case presentation on interprofessional care. Then students in each cohort discussed the case, examining literacy from different disciplinary perspectives. And the last project I'll share with you involved creating patient diabetes education resources for the Virginia Garcia Memorial Healthcare Clinic, an FQHC on the Pacific University College's campus. I worked with our nurse diabetes educator to create low literacy patient education resources. The clinic serves a very large Spanish-speaking clientele, so we created bilingual resources and we posted them on the clinic staff's intranet so they could have easy access to them to share them with patients. We focused on using pictures to tell the story and did our best to use plain language in the words that we used. In all, we created 14 bilingual handouts on topics from foot care for people with diabetes to the healthy eating plan, or excuse me, healthy eating plate that you see here. And that's it for me for now. Thank you for allowing me to share my perspective of health literacy and some novel approaches.
Thank you so much. That was fascinating, and you have done many novel strategies. I think those are great. And for anyone that didn't see them, there's a number of those mentioned in the chat, so please do visit. And so with that, I will now introduce our next speaker. And so our next speaker is Dr. Naomi Jamal, who is the Chief Health Officer with Swope Health, and she'll be providing the FQHC provider perspective on health literacy quality improvement measures.
Hi, everyone. Good afternoon. So I am going to set this up. Do you see my slides?
Yes, we sure do.
Okay, great. Thank you, everyone. Just wanted to go ahead and kind of give the federally qualified health center perspective.
No, I think our team did a good job. It was good.
1 second. Please mute if you are not the speaker. Thank you.
Okay, so wanted to kind of give the federally qualified health center perspective. I am the Chief Health Officer at Swope Health, and we're fairly focused around health literacy concepts because, as Michelle just mentioned, it is intricately involved with health equity, and that ends up being very, very relevant to the patient population that we serve here in Kansas City. So we'll be going over some key definitions. This section shouldn't be too long. A lot of these have already been introduced. And then more specifically, really looking at some quality improvement measures, most of them taken from the AHRQ, that really look at health literacy more as something from a quality perspective, and unpacking that a little bit and how one can use those in clinical practice to kind of gauge where we are with regards to health literacy and how we provide care to our patient population. And then as we kind of go through those quality metrics, we'll also be talking about some challenges that can inherently occur when attempting to build a health literacy program and become a health literate organization. So these definitions, again, have already been laid out. So really, understanding this concept that there are two different types of health literacy, if you would. I think when most people think of health literacy, they immediately jump to this idea of personal health literacy and are fairly familiar with what that means. From a healthcare perspective, however, we really also need to be aware of organizational health literacy as well, and what that incurs or means when we're really attempting to provide equitable care to our patient population. And so what those quality improvement metrics look like and what that means from an FQ8C perspective is what we're going to unpack next. And so the Institute of Medicine really had, to become a health literate organization, it really says that there are about 10 attributes that need to be met in order to meet that. Much of that revolves around leadership promotion, really coming up with plans and evaluations and improvement measures that look at health literacy similar to any other quality metric that you would look at, really preparing the workforce, training them to become more health literate and have a health literate outlook when providing care, ensuring easy access. Communication, of course, ends up being key, really looking at coverage and costs and explaining what that means. If anybody has been on the receiving end of our healthcare system, that ends up being fairly challenging and a huge barrier to patients, especially those who may be dealing with issues of not being insured or being underinsured. It ends up being a major barrier to the care that they receive. Again, targeting high-risk populations, designing easy-to-use materials. Michelle touched on a lot of those through some of the novel approaches that she mentioned, but it ends up being really a really important tool when viewing things from a health literacy perspective. It's also meeting the needs of your entire patient population and not just those that we may find it easy to communicate with, including consumers in that conversation as well. So that really is getting the patient perspective as well. And we'll talk a little bit more about that with regards to specific quality measures. And so overarchingly, if you were to look at this from a design perspective, to become a health literate organization, you do need to view the organizational structure, policy, and leadership itself, and really bring in policies that are specific to health literacy right at that organizational level and really making it the fabric of the organization itself. And then largely then broken down into areas of communication, ease of navigation, and patient engagement and self-management support. So from an FQ8C perspective, I think a lot of these measures, when you kind of look at them, there is a consensus organizational health literacy quality improvement measures that are out there. A lot of them are very hospital-based. So what we've done is really modify them and taken some of those up and seen how we could really make them a part of our organizational fabric and our quality as well as health equity program at the organization. When we've attempted to break those down, very largely you're looking at leadership support of health literacy efforts. And again, that's a quality measure that you could really look at when you're attempting to break that down, is looking at the percentage of leaders who attended health literacy awareness activity, or if you're even providing that to your clinic directors, clinic managers. So as you're thinking about leadership, it's not just executive leadership, but leadership at every level of the organization. Patient family engagement, leader or functional areas, so really looking at, here it says hospital for us, in the FQ8C world, you're really looking at that from a non-hospital environment as well, and really looking to see if you have a person or a functional area that is designated to perform that function. This is something, again, that most organizations are moving towards, but the challenge here ends up being when you're trying to develop a patient and family advisory council or some sort of representative. The key is to really use those councils in quality improvement teams as well. So you don't only have quality improvement teams that are entirely encompassing providers or care team members, but you also want patient input on some of these quality improvement measures as well. That sort of goes a long way towards health, becoming health literate. Again, the quality metric for that would be really seeing if you have a PFEC in place. At SWOPE, what we currently have incorporated inside of our health literacy and quality program is that we do insist that at least 50% of our board leadership and membership are actually members who have availed themselves of services at the health center itself. So as even, they're coming up with policies or major organizational decisions for the entire organization, at least 50% of those members it often ends up being a higher percentage, have actually received services at the health center itself. The other domain really that we were looking at was communication as well. And so you're really looking for screening for preferred spoken language for healthcare. So everything that's highlighted in yellow are things that we actually do at the FQHC and how we've modified them. So it's really keeping track of percentage of outpatient visits for which preferred spoken language for healthcare was identified and recorded. We actually have a percentage that we are required to meet. And kind of track that on a quarterly and monthly basis and share that with relevant and appropriate care team members. It's also looking at patients receiving language services that are supported by qualified language service providers, and so really developing a metric around that as well. And then again, receiving language services during specifically consent discussions. So really kind of keeping track separately and making that a separate quality metric that we track and look at. Other things, of course, are also looking at staff training of the use of the teach back method, and kind of again ensuring that that is done in a language that the patient speaks, and then patients correctly teaching back. Over here it says back after discharge, again very much using the verbiage of hospitals, but in the outpatient setting, it is after visit summaries as well. So we also provide after visit summaries after each clinical visit, and sort of making sure that that is accessible in a language that the patient speaks and the patient really understands that. Again, only about 1 in 10 of our patient population across the United States have really said that they understand or have the health literacy skills needed to kind of unpack the discharge instructions that they're often given. And then care for older adults, doing medication reviews every visit, every time, and really being focused. Again, this is something that we do for our entire patient population, but especially being focused on older adults as well, because that population tends to really be challenged with polypharmacy. Ease of navigation, and again, this is really looking at follow-up appointment scheduling as well as referral reports and they're being received, so essentially closing the referral loop. Again, both of those metrics are regularly followed and on a quarterly basis are shared with care teams and at multiple levels of the organization. So really using them as quality improvement metrics that ultimately are geared towards health literacy as well. Inpatient education, again, this is very much in the inpatient world, but outpatient as well. We kind of have taken that and modified that to suit our outpatient needs, specifically in the FQHC world. We also do fairly stringent SDOH screening. We do that by using the Prepare form, which is a standardized tool used across the organization. So really making sure that we're screening for the social determinants of health, and then also, connecting patients to community resources in a language that they speak and in a culturally proficient manner. A similar thing is done for referral of non-medical needs as well. In our setup, that primarily ends up being social determinants of health related. Self-management goals, in addition to care management programs, it's really looking at, for instance, percentage of patients with diabetes who have set self-management goals. This is something that we track through a quarterly peer review for each of our clinicians that provides any kind of diabetic care. We also kind of, in addition to that, have added other metrics, such as making sure that our nurse care management programs, all of the NCMs, if they serve in a specific clinic where the patients are primarily Spanish speaking or have other language needs, that we have an NCM who is of a similar cultural background and proficient in the language spoken by the majority of the patients at that site. We also kind of look at planning checklists for scheduled admissions, again, really being focused around pre-visit planning and making sure that we are giving pre-visit planning forming pre-visit planning structures for our patients. Again, in the outpatient setting, in the inpatient setting, it's really looking at scheduled admissions, and in the outpatient setup, we've really just taken that metric and modified it to cover pre-visit planning as well. We're also then looking, again, this is a very outpatient measure, which looks at shift in change huddles and bedside reporting. Again, in the outpatient setting, we've just decided to primarily focus around pre-visit planning and making sure that that is done in a health literate way. And then instead of post-discharge phone calls, we've modified that to really look at discharge coordination. So making sure that our patients who are seen at hospitals, how do we get them back into care, making sure that they have appointments with their primary care providers. And again, that we're doing that, keeping health literacy principles in mind. And then finally, that there are several measures that cut across several domains. And these are kind of the different tools that can be used to kind of really assess where you are as an organization with regards to health literacy. Finally, wanted to just highlight the fact that even in Healthy People 2030, as an organization, more and more entities are really looking at health literacy itself as quality metrics, as opposed to just the traditional clinical quality metrics that we tend to look at, which basically revolve around chronic disease measures and things of that nature. I think one of the key things to highlight here is that it oftentimes, when we think about clinical quality metrics, we immediately think of things such as diabetes measures or measures related to hypertension control, but none of those measures, such as even an A1C rate, is really valuable to the patient. I think if we really come up with patient-centered metrics, a lot of those metrics will revolve around things such as health equity, health literacy, cultural proficiency, and so we should really make an effort to incorporate more clinical quality measures that are patient-centered and will probably have a far greater outcome on their health outcomes. Thank you.
Thank you, Dr. Jamal. Stacy?
Yeah, that was amazing. Thank you so
It
much.
was.
So much information there, and I really appreciate your perspective. So thank you. And we'll now be turning it to hear from a community-based organization perspective, specifically navigation programs and patient health literacy for Spanish-speaking communities. And we'll be hearing from Erica Andrade, who's the Chief Program Officer for El Centro. So the floor is yours.
Hi, thank you. I'm going to share my screen. Let me know if you can see it.
Not yet.
There it is. Are we good?
There we go. Thank you, Erica.
Sure. So my name is Erica Andrade, and I work at El Centro. We are a for-profit organization. For-purpose organization with 45 years of serving the Latino communities in Wyandotte and Johnson counties in Kansas. I'm the Chief Program Officer, and I have been with El Centro for 20 years. Prior to being Chief Program Officer, though, I had the great honor of actually beginning our health navigation program with El Centro about 13 years ago. And that's kind of, we were doing work with health literacy and health navigation before, but we just called it a medical case manager. And as people came in needing assistance, we kind of just, played it by ear and try to get them to where they needed to go. After that time, we kind of organized ourselves into a true health navigation project here in Kansas City, Kansas first. And now we also hold it in Johnson County. El Centro began with a small grant of $10,000 from the Archdiocese of Kansas City. That's why a lot of people will see that cross in our logo and think that we're a Catholic-based organization. We are no longer affiliated with any religion, but we just keep it to honor kind of that beginnings. Our founder, Richard Rees, once said that no funder will ever determine our existence. So El Centro is very much always striving to do programming that's sustainable, that's necessary, and that's adaptable to the needs of our very specific community that we serve. Our mission is to strengthen communities and improve the lives of Latinos and others through educational, social, and economic opportunities. But most importantly is our why, the why we do what we do in the community. And what we say is that at El Centro, we believe that all individuals, regardless of language, place of birth, or documentation status, deserves to be fully accepted and integrated into the communities they live, work, and pursue their dreams in. We are all part of the community, but here at El Centro, we are all welcome as family. The target populations that we work with and some of the barriers that they experience, first and foremost, El Centro is proud to say that we are a Spanish first organization. What that means to us is that all of our services, all of our education, all of our programming is done in Spanish first. It's created in Spanish and then translated if it needs to be translated. Some of our program is actually not even offered in English. Our service, we focus on working with Latinos, mostly multi-generational immigrant families, some of who are undocumented or come from mixed status households. They're Spanish speaking, low-income individuals, and a lot of them are either uninsured or underinsured. So they have a lot of health access barriers, as well as being able to financially access the healthcare that they need. Although we are known for working with Latinos, we do work with anybody that is able to come into the doors and that we're able to help with our programming. A few years back when we did our theory of change, we did a huge community assessment and we updated it every few years. And the same, 5 basic barriers have risen to the top as the items that our community has kind of assigned to being the things that they experience the most barriers with, and those are immigration, the lack of culturally and linguistically appropriate services, low education attainment, lack of health access to affordable health services, and then low wages and lack of benefits in those jobs that are available. The way that we are able to do all of our programming, which here in a second I'm going to get into our health programs, is really because of our dedicated staff. All of our staff that works with clients, directly with clients, are all bilingual. So they all speak English and Spanish. More so than that, most of our staff, I would say about 95% of our staff, will share similar cultural experiences with our clients. So they all come from diverse Latino backgrounds, some first generation, some immigrant, and some that have been here for multiple generations. It's also really important for us that our staff actually live in the place where they work in. So most of our staff that's here in Wyandotte County live in Wyandotte County, and all of our staff from Johnson County lives in Johnson County, so that they really understand the communities that they're serving. We also benefit, and probably what sets us off apart from a lot of other community-based organizations is we benefit from a strong team of promotoras de salud and community mobilizers. Promotoras are, it's another term for community health workers, though we do see a difference in the way that we recruit, train, and then how they work with us. So these are, right now they're women. They could be men, but most of the time it's primarily women. These are natural leaders in our community that engage with us through programming that either express that they would like to do more, or we see potential in them and we invite them to become a promotora. They will get training, leadership training, how to have difficult conversations, and then also focus training. So they'll learn everything that they can about Medicaid or about healthy eating. We have a class that we do called Comprando Rico y Sano, which individuals will learn how to cook healthy Latino recipes, how to shop for them, all at a low budget. And so we're able to do a lot of these programmings through the work of our promotoras and community mobilizers, which are volunteers, though we do honor their work with stipends. So our health navigation program in particular. So the health navigation program is about coordinating care to eliminate the barriers to access quality healthcare services. That was the main objective or the grand goal of why health navigation was created. We have 5 core programming services that we offer through our health navigation programming, which is direct services. We're a Kansas City Medicine Cabinet site, which means that we have access to those vouchers so that individuals can come to us and get eye exam, eyeglasses, dental care, prescription assistance, durable medical equipment, things like that. We also have some funding support from local foundations, so we're able to do things like help individuals with down payments if they're needing surgery that they have to pay for out of pocket if they're uninsured, and we also have those kind of funds that we can help with. We do insurance navigation, which means that we can talk to individuals and families about what their coverage options are. So do they qualify for Medicaid, Medicare, the marketplace, maybe private insurance through their jobs? and really do a lot of education and outreach around that area. We have a whole program called Inscríbase, which means get enrolled, and we talk about all public benefits. So the idea is that any individual that comes in through our doors, regardless of what they're coming into for, they might be coming in for something completely different, like a lawyer list or a referral, or they need help with utility assistance. They will get a full intake and a full assessment created so that we can see what other areas that we can work with them on. We do billing navigation. So as we know, sometimes there's accidents and you have to go to the emergency room or you have to have surgery, and then you get a lot of unexpected bills, or, you went in for an hour and now you have 5 bills and they don't know what to do with this. And so we do a lot of work around billing navigation, which is explaining why there's multiple bills for just one visit. And then also coming up with a plan of either how they can either apply for charity care assistance, which some organizations have, and then we can help them apply for that, or coming up with a plan to pay back so that they can avoid collections. We do a lot of specialty care coordination and medical interpreting. We work with WIJO Care. And then we also have clients that don't go through WIJO Care, but are referred to us through actually the Safety Net Clinic system, where we can help them navigate and getting into specialty care when they're uninsured. I'm sorry to say that, our healthcare systems do not make it easy for individuals that are uninsured, uninsurable, to get specialty care assistance. Our Safety Net Clinic systems, or FQCs, do an absolutely wonderful job providing primary care. But there's, at a certain point, individuals that need specialty care will get into roadblocks, especially the population that we work with. And so we work with them to kind of guide them every step of the way, trying to find a way to get them into the healthcare system so that they can get the treatment or surgery that they need. And then we also do a lot of patient advocacy and public services. So really everything that El Centro does at the end of the day is about advocacy. It's about health equity. It's about reducing barriers. And so that's a really big part of what we do with the community. We inform and educate, but then we also work with organizations and institutions to make sure that they are doing equitable work and they're not discriminating against the population just because of language barriers or documentation barriers. For patient health literacy, our policy is to use terminology that is below fifth grade level, and this is of course in Spanish, making sure that terms are not just the right language, but they're culturally relevant. Latinos cover a wide range of individuals from all over the place, and it's different languages. Here in Kansas City, the majority of Latino immigrants are still from Mexico, but we're getting a lot of influx from Central and South America. And there are terms that we use. I'm a Mexican American, so terms that I might use in my Mexican Spanish that is not recognized in other languages. So we have to be up to date to that and make sure that we're designing educational materials that's really gonna allow everybody to understand what we're talking about. We also create all of our materials in Spanish. They are not translated. There's a big issue when things are created in English and then tried to be translated into Spanish. A lot is lost. It's just not going to work the same. So really working with individuals where Spanish is their first language, and then having them create the materials themselves along with the input of the community during the development phase, like working with our promotoras and our mobilizers to actually create the materials ahead of time is going to save a lot of time and heartache when things are not useful after there's, spend a lot of time and money creating them. And the most important thing that I would say about patient health literacy is that we rely on visual forms of education more than we do on the written. Using social media and other platforms is really the way our community communicates a lot. So we do a lot of videos, educational videos. We do a lot of pictures also so they can kind of understand and see. And then also when you're using media and when you're using visual aids like that, it's also important that those are culturally appropriate. Are you using pictures of individuals that look like them, people from the community? Are you using pictures of foods that are the foods they eat and not something that they have never seen or understand how to relate that back to how is this related to my health? So those are things that are really important when we're developing products. So fear and informed decisions, this is I think my last slide. Even with a shift in the political climate, there's still a lot of fear in the Latino community, which is real and legitimate. And we have to at first make sure that we understand that when we're dealing with an individual, a Spanish-speaking client or patient, that they're coming with a set of traumas and a set of experiences that might not be what you're used to or what we consider the norm here in America. So when they don't look at you in the eye or they don't respond to questions, they're not It's not that they don't care about their health or are disrespectful. It's just, that was my timer. It's just that they're coming from a different place. They have a different set of experiences. Also, discussion options with clients and providing the most accurate information is best so that they can make a decision that's best for them is really important. You have to make sure that they understand all of the situation. You give them options, and at the end of the day, the decision is theirs, and it's not just you imposing your thoughts and values and decisions on them. And then also when you're asked, this one I cannot stress them enough, when you're asking for sensitive information, like when you're doing paperwork, such as to make, you know, when something happens where you have to ask for immigration status or security number, do that in an appropriate way and ensure confidentiality is maintained, and don't ask if it's not necessary. If you don't need certain information, just don't ask it, because all it's going to do is going to create a barrier and create a wall that's already going to put you at a disadvantage with the clients that you're trying to serve. And that's it. Thank you very much.
Thank you, Stacy. Thank you so much.
Yes. Thank you so much. That was great. Sorry, can you guys hear me okay? Maybe not.
Yes, I can hear you.
Okay, I was like, I was having a frozen camera moment there. So yeah, thank you so much, Erica. That was really great. I loved hearing a lot more about everything that El Centro is doing in this space. That was really informative. So now we will turn it over to Dr. Carly Zeggers, who is on the advisory committee for the Wyandotte CHIP and is assistant professor in the KU School of Nursing and an emergency department nurse practitioner at University Health and Truman, with kind of a health policy perspective on more than just reading and writing, how understanding and applying health information matters more. So the floor is yours. Thank you.
Carly, if you're speaking, we can't hear you. There you go.
Screen okay? Perfect. I got unmuted. Can you see it okay now? Perfect. Wonderful.
Yeah,
Thank you
yes,
all.
it looks great.
It's been years now. You think this unmute thing would work. I appreciate this opportunity to be here and this incredible panel of people. I am coming at health literacy from a lot of perspectives, different hats, as a researcher, as a practitioner and provider, and also in this beautiful role now that I have with Wyandotte County in the CHIP program. So I wanted to speak today to kind of advance what has already been said today, but think about it in a little bit broader sense in terms of health policy. But I first want to get started with the idea of a definition of health literacy. So we've been presented with a very informative definitions, but I want to think a little bit broader. And in my research, I have found that health literacy traditionally in the United States, which we talked about a lot today, sits in this functional world where it's the ability for individuals to obtain that relevant information and apply it for the activities. But I also want to think about this opportunity to think in a broader sense of communicative health literacy, which was brought on by Nutbeam in the early 1990s. And man, that seems not that long ago. So communicative health literacy, which is more of the ability for individuals to interact with information and derive more meaning from it with that communication and applying it to new situations. So if I have information about, say, diabetic issues and knowing that access and having that communication skills, I could then learn about health, like hypertension quickly because of that communication skill. Then additionally, critical health literacy, which is this much more advanced ability in its cognitive skills, which together with the social skills in social settings can be applied critically, analyzing information and using it to exert greater control over their health. So looking at health literacy, and in the title of my talk is talking about how reading and writing is important and having like accessible handouts and discharge paperwork and that 5th grade reading level is important. But I think more importantly is our time that we take to communicate and our time we take to empower and embolden individuals to engage with information about their health and asking those questions and pushing towards those next steps. And I think we've heard about that today. So we've seen a variation of this picture in terms of the equity and justice. So in inequities is one person getting something without others. That equality is both getting ladders, but might not be needed or helpful. and then that equity where we get the correct size ladders. But then this idea of justice, which is where we're straightening the system out. And this is truly looking in our policies, looking in what we do on a daily basis. And from that organizational level that was previously presented, what are we doing on a day-to-day basis where we have to disengage, maybe re-engage or re-envision how and what we're doing in order to move forward. And this is where I think policies lie. This is where we go through and really find how are we doing the habits that we're doing? How are we engaging with what we're engaging in? And what are we doing to make sure that our clients, our consumers, our individuals, they can interact with what we're talking with them about. And we have ability to communicate by building trust and by building relationships and understanding. Building understanding to make sure that we are moving past this barrier of an us versus them situation. And it's this ingrained with cultural humility of we have information and knowledge is power. So how do we exchange this power and level these power dynamics out so that policies support us to deliver information in a way that people need it, when they need it, and the way they need it, about what they need. That's basic little stuff. So jumping into the CHIP work that I'm doing with an amazing group of people, we are, the Wyandotte County CHIP program has a health literacy subcommittee. And what has happened in the past in 2019, so it seems like centuries ago, pre-pandemic, there was focus groups looking at literacy campaigns and looking at the infrastructure to build this campaign and technology and coordination. What was really cool is that we were addressing this long-term health literacy issue through development and implementation of these media campaigns, improving local services, reaching individuals and residents in WYCO to make sure that we are increasing the idea of uptake of insurance, having a primary care provider, and then kiddos in kindergarten with immunization. So those were our evaluation metrics for our goals to see if we're doing a better job. And I really love to look at the health insurance primary care, because that is also an access issue, right? And then with the kindergarteners with immunizations moving up, there involves trust in that. Trust and access is really ingrained at all of these levels. And that's where I believe health literacy lives. So the first campaign came out and that there was this information dropped into the community, experiences giving bilingual information by individuals you can trust. You can see the Spanish version, and actually multiple languages were used for this, which I think is really cool. Unfortunately, when you do evaluation, and fortunately, you find that there's still limitations in what you do, especially with print, right? And even if it's in 5th grade, it doesn't mean that people can hold on to it or understand it or use it or engage with it. So the Spanish did great, but I think a lot of it had to do with the algorithms and target audiences and platforms and the partnerships used. COVID-19 destroys everything, like always, and we will be able to blame that for a very long time. But I also think that we can step back and take a good issue and use it as a strategy, right? But I want to kind of highlight this last area. This is the bulk of where I believe health literacy needs to live, and that's really looking at reimbursing community champions and translation services to get the information diffused and disseminated and distilled in the communities. That's where the communication and the critical health literacy of application and contextualizing information goes back to the people. So our next steps and how are we going to integrate these ideas of communicative and critical health literacy? So the campaign, we did get really good funds. I'm really excited that we have this opportunity to move forward with some funding to do some campaigns. We're first going to start, because like everyone has said, it's about the community. So nothing, the ADA has this amazing slogan called "Nothing about us without us." And I live by that and I thrive by that. So, but to also address power in the community, we're actually going to break up and we're going to do a diversion conversion theory with 2 different cabs. And one is going to be the community champions, community members. And then we cannot leave out those industry and organization as well. So having 2 different cabs in that sense, because the application of these strategies will not be effective if we don't have their viewpoint as well, right? Like how are we going to embody and embolden translators and interpreters to do their work in the best way possible if we don't have that area? And then we're going to pull them all together. So have separate so that there's no power dynamic, and pull them all together so that we address and show that there's collaboration between the groups. Some of the ideas that we're coming forward with, and definitely going to be directed by the CABs, but something that I think is important is disseminating this information. So having those QR codes, having them scattered and available with resources on our various topics that we're focused on. Something that I know I've been very successful with in terms of that communicative and critical health literacy application is the idea of a healthcare glossary. So even in 5th grade terms, our language, and most of the time in our provider meetings, I don't speak at a 5th grade level. And it's really hard to even get back to that plain language because it's not common language. Medicine is a different language. And you'll ask any healthcare provider student that, you're learning a new language completely. So we really have to understand how to go from medicine to whatever language our individuals in. So if it goes to English, but to the level of language that they are able to interact and engage with. And it's not being offensive and speaking down to somebody or speaking like trying to go down to them. It's not about going down to anything. It's about engaging and communicating and going back to a person-centered relationship with an individual. So with this healthcare glossary, which is really exciting, I did it with a Hep C group, so hopefully we can bring it here. And it was a 20-page English and Spanish guide to what the heck those terms mean in your handouts. Basic terms, including like diagnostics, like what the heck does that even mean to somebody? And I really, Miss Andrade was amazing when she talked about the Spanish first. I have a partner in crime. I'm Hispanic as well. I have a partner in crime. And so when we sit down, we talk, we actually do the English and Spanish in our first languages. So I do English, he does Spanish, and our definitions play off of each other, but they're totally contextually appropriate. So it's not English and then to Spanish, it's English and Spanish. And it's acculturated because culture is involved in these conversations. A Medicaid resources is getting these out there, and we're thinking about doing like a worksheet so people can fill this out. And one of the most annoying things I ever did growing up, and I grew up in a socioeconomic family, is we'd get somewhere and didn't have the right paperwork. We'd get somewhere and we needed another piece because someone didn't tell us about that. Or we got somewhere, I mean, it's like the DMV all the day, right? And I wish I could just go to one place with one worksheet that I knew I could collect all of these things and have them ready to go in order to fill out the forms necessary. So those are some of the resource options. And then finally, we're thinking about an empowerment toolkit. And this sits in that communication and critical health literacy world where we are going to develop a toolkit, and this is based on the CAB, but the goal is then to develop a toolkit where we challenge individuals to ask the questions and provide questions that they can ask to prompt their healthcare providers to speak to them in a different way, to engage, and maybe not coming out and saying, I don't know what you're talking about, but asking those specific questions saying, hey, I appreciate that you're trying to teach me, but I'm not sure I get it. And giving those prompts and permissions to our community members to challenge our healthcare providers to do a better job and really engage with them in a better way, in that more health literate way. So those are just some ideas that we're coming up with, and hopefully I kind of made you think a little bit and chew on what health literacy is a little bit differently, and maybe advance it past that 5th grade reading and writing level. And this is my last slide, and I'd love to get to work. So time to get to work, and that's my 2 cents.
Thank you so much, Carly, and everyone. Dr. John Spertus is on the line and will carry us through Q&A.
Actually, I would love to do that, but I fear, I've been on clinical service. I missed so much of it if that I just couldn't give it justice, and I just didn't want to miss it. But pending clinical responsibilities impaired my ability to participate fully, and I'm so sorry about that. But I do want to listen to the discussion, if you wouldn't mind, Pat, leading that.
Absolutely not. Thanks, John. There was so much information here, so much wonderful information. I know I'd been taking notes, and just as soon as I had a question, someone answered it, and I just have notes and notes and notes. Who has questions for us? The information was wonderful, focused on patients and organizations. So I'm sure someone out there has questions for us, and we're happy to have presenters respond to you. You can come off mute for that, please. Did I see someone
Yeah, you
flicker? Yes, Mary
You did.
Ellen, thank you.
Hi.
Thanks for
I'm a
kicking us
colleague.
off.
Yeah, I'm a colleague of Dr. Ziegers, and I'm also at the University of Kansas School of Nursing, and I'm a faculty member there. And I have a question for Dr. Jamal. I was really interested in the way you presented the organizational health literacy quality improvement measures, and you applied those to your institution. Are you aware of any research that's been done across the country about how many hospital systems or other types of institutions that are healthcare driven meet those types of metrics?
So they're actually all over the place, to tell you the truth. The metrics, in the sense, even the ones, the specific quality measures that we've kind of taken and then really modified to our setup are and actually a consensus guideline that was developed with consensus. EHRQ and the Institute of Medicine worked on it, but it's basically a consensus guideline. I think a lot of the measures that we've looked at, the closest that you could probably come to that I can think would be organization-wide, especially in the outpatient setting, would really be looking at two data sources. All federally qualified health centers are required to really report out some of their metrics, not all of these, but some of these metrics through what we call the Uniform Data System, UDS. So some of these metrics you would actually find reported, and they get reported annually for every single federally qualified health center. So you actually get them by health center, but then you can also see that data by state and then also across the country as well, but it's very much focused in the FQHC world. The other, I think, source that you would really find some of this data, although I don't think they publish theirs as frequently or as transparently, would be PCMH data. So through the NCQA, the National Committee of Quality Assurance, any clinic that is a patient-centered medical home, which almost, I think over 60% of federally qualified health centers are now, but even outside of the FQHC world, many, many outpatient primary care settings are now patient-centered medical homes. So some of these metrics, especially the ones with regards to referral loop closure, having either a PFEC or having about 50% of your board members actually being patients at the organization, and several other care coordination and navigation metrics are actually a requirement to maintain PCMH status, and you have to report on those metrics annually. So you could pretty much, I think, through the NCQA, get some of that data as well in the outpatient world. But to your point, Mary Ellen, no, it isn't. Unfortunately, I haven't found anything yet. I'm very hopeful, though, because Healthy People 2030, as I kind of mentioned at the end, had far more health literacy targeted or geared quality measures than we've seen in Healthy People 2010 and Healthy People 2020. So there seems to be sort of this universal shift happening in the quality world, really looking at health literacy as a quality improvement metric outside of those traditional clinical measures that we typically look at.
Great, thank you very much.
Thank you again, Mary Ellen. We have a couple of questions I see dropped here into the chat. Let's see. Is the health glossary available online currently? We have a lot of links to amazing resources higher up in the beginning of the chat. A glossary,
We're going to have to develop that. Yeah, it's an idea, and we're going to be guided by our CAB. So once it is available, Jack, I'd love to send it to you. So WICO will have their very own, and I think we're going to focus on primary care and some of the core elements. So I'm sure that our friends here at El Centro and SWOPE will probably also be disseminating that once we get it going and whatnot as well. So it's not there yet. We'll get there, I promise.
Where can we go to keep snooping to see if it's released yet?
I think I might phone a friend. Susan, are you on?
I am on.
Susan, can I phone a friend? What's the best place for
for people to keep,
Yeah.
you know,
Yes, absolutely. I will
peeking.
drop them in the chat, but we do have a community health improvement plan dashboard page. We'll probably house it there, and really any organization that's involved in the work. We'd love to put resources wherever we can, but the central location would be our CHIP dashboard. So I'll share it here in the chat. We also have a WICO CHIP newsletter. So we send out an email newsletter quarterly, and it sort of summarizes highlights, progress across each of our teams and areas. So that would be another great way to stay in the loop.
Thank you. Thank you. Thank you. Nick Marcello asks, Dr. Spatz, how did you implement the discussion around health literacy through different professions as lenses into your program's IPE training?
Well, for one thing, I wish I were Dr. Spatz, but I'm not. So I just want to be upfront about that. Maybe someday. Anyway, I think the most effective way we did that was through the Interprofessional Education Case Conference. So this was a case conference that students were required to attend. They were sent in different cohorts. So there might be, 6 pharmacy students and 6 physical therapy students and 6 PA students and just all the different professions. And when they arrived at the case conference, they were put into an interprofessional group. So they were assigned a table and they couldn't sit with their, classmates. They were in an interprofessional group. There was a sort of a didactic training portion that would begin the case conference, and then the case was shared. And the case, if I recall this was a few years ago, but it was an individual who was from he spoke, his native language was not English. He had a complication with his chronic illness and ended up receiving care and needing care by a number of different health professionals. So in looking at the different aspects of the case, the care that was provided, the types of communications that were shared, the students were able to examine that case from their specific perspective, their discipline their discipline specific perspective. And it was very interesting to hear them share and realize that, at the end of the day, they all had the patient's best welfare at heart. They had different contributions, but they were all important. And they learned from each other some appropriate ways that they could improve that patient care. So I hope that answers your question.
Thank you. Did that? Oh, yep. He says, thank you.
Okay.
So while we have these powerhouse insights, keep questions flowing, and you can also please feel free to come off mute. Would anybody else like to ask a question? Going once. Going twice. Going twice.
Oh God, it's me again.
Oh, great. Yes, please.
I always have questions or comments, and I'm known at the School of Nursing whenever we do public presentations that Dr. Potts will always have something to say. So
excellent.
I just want to add a comment to consider as we think about health literacy, particularly institutional, organizational, as well as kind of one-on-one with patients in the healthcare system. I had attended a while ago a wonderful presentation on nursing philosophy. And the concept that was being discussed was the opacity of healthcare institutions. In other words, the lack of transparency, which was discussed right by Dr. Jamal. and how that opacity vulnerabilizes the patient even more than the label of patient vulnerabilizes them. So you're really putting them in a one down position right from the get-go. And that concept to me of vulnerabilization is something that I think needs to be considered when we're talking about health literacy or anything concerning patient education and empowerment. And I just wanted to share that thought with y'all.
Thank you.
Yeah, absolutely. Thank you for mentioning that, Dr. Potts. And I mean, my 2 cents would probably be, as you speak about that element of, opacity and lack of transparency, because as we've all spoken about this, and I think the other speakers alluded to this as well, I think it really sort of goes back to philosophically, at least in the outpatient world where we find ourselves, because now we're kind of in the space where it's, even with value-based care and the move towards value-based care, we're still kind of very much operating in a space where you have to meet a certain goal or certain number of patients seen in a day, so you get that 20 minutes. And then, so there are 2 ways of doing that. Either we change things around where our frontline providers, physicians, NPs are allowed more time with the patients. And so you can have a 40-minute visit as opposed to a 20-minute one. Or then we start reimbursing different team members and their work towards health literacy and health equity, whether that is community health workers, medical interpreters, key team members, and even now our insurance setup is such that those key roles are not entirely reimbursed. So I think it's also a great opportunity to look at our payment models as we look to further health literacy inside of clinical care.
Yeah, those Z codes. I wish we could start paying for those Z codes and billing across. I agree with that. And mine I add as well. We have work to do with, like, post-pandemic. Our trust as healthcare providers is very, very on edge at the moment, if it's not already gone. And so we really need to consider how we are reaching back out and going back into the community and repairing that transparency, as we know that power lies in information and information exchange. Like, that is very much so a point of what's going on. And now with the media and the misinformation that goes out into the world, and I mean, I don't know how many times I work in the ER, and just anecdotally people coming in with just some of the, like, I have kneecap cancer. I'm like, what Dr. Google sent you down this path? Like, where are we at here? And really establishing that trust and having that transparency is going to be huge, especially for our panelists here, like from our FQHC and community standpoint. And that's where it's going to start, because I don't think our systems have that figured out quite yet. And so really leaning on our community partners and our advocates in the community to increase that transparency and increase that ability to penetrate healthcare. I think that's going to be a big thing as we start correcting, and that's a fallout from the pandemic that I don't think we've addressed so much. So.
There's more conversation going on in the chat, but I think a lot of it is being covered in the discussion. Any new questions?
I just wanted to make a plug if anyone would like to join the work of the the CHIP Health Literacy Subcommittee that Dr. Zegers mentioned. You can reach out to her, or you can reach out to myself, or by just putting your email address in the chat, and I'll be sure to include you in the next meeting that we have as we build the CAB out and look to work with other organizations, as she mentioned, in the community, and just really figure out what specific work we want to do around the health literacy campaign or project, the glossary that she mentioned, just all the different projects that we're thinking about. If you want to be a part of any of that, please feel free to join us. We would love to have you.
Please, if you don't mind, share your email address and I'll drop it in the chat.
Absolutely. Thank you.
But tell me, are you going to drop it in the chat, or do you want me to drop it in?
Robert, can you throw it in? So Robert's my counterpart working the subcommittee chairs, and he is our amazing CHIP coordinator at Vibrant Health. So he's a rock star. Robert, do you care if you throw that in the chat for everybody?
No, no problem. I'm doing it right now.
Thank
I
you.
appreciate you.
Thank you. Thank you.
And thank you for that introduction, Carly. I forgot to mention who I was. I just
Yeah,
randomly started
he's our
talking.
amazing person.
Sorry.
He's the one that keeps it all together for us.
I'm trying. We have a great team of folks. So thank you again for the presentation. And this was a great discussion. I came in at the end at a previous meeting, but I'm glad I caught what I was able to catch. So thanks.
Thanks for joining. Any more comments or questions? Oh, Michelle, were you about to speak? Yes,
I
please.
was. I have a comment. One, October is Health Literacy Month, as we all know, so yay. But I also wanted to make a comment about the healthcare environment itself, and thinking back to the health literate organizational assessment I did at the comprehensive psychology clinic at Pacific. And in using that tool that I mentioned by Dr. Rima Rudd and her colleagues, it was really an eye-opener because, you know, we're so at home in our clinics and our hospitals, we're at whatever our healthcare environment is. But when patients come to us, it's like a foreign country to them. And this tool was very helpful in looking at, you know, putting yourself in those shoes of I'm new here. And then what do I see when I am trying to approach the building? And in this case, people got off of light rail and had to try to find the clinic. And so what does that look like? How is that navigation? When I walked into the psychology clinic, you know, I'm imagining I'm a patient, I'm stressed, I'm anxious, I'm worried, all of those things. And I'm bombarded with the regulatory signs and then the directional signs and then all the different posters and things about, you know, support groups and things that I can avail myself of. And then when I walk down the hall to my treatment room, what am I seeing? You know, and just, you know, just a number of different sort of visual bombs, if you will. So I just want to kind of put it out there. I don't think we really talked a lot about this, but the physical environment itself really does have an impact on our patient's comfort level. And I do think it can impact their ability to understand, you know, their care and treatment.
Thank you. Thank you. Any further comments or questions? Robert Gibson did drop some information in the chat about how to get involved with Wyandotte County CHIP. All right. What was I up to? Going twice? Going twice.
Pat, I'll just say that I live in Seattle, and but if I lived in your area, I would join your CHIS.
Terrific. Terrific. Going 3 times. All right, everyone, thank you so much for presenting, for the rich conversation. We can't thank you enough for bringing your special insights and wonderful expertise to the panel. And everyone who came, we thank you, and we always welcome your feedback and input and even program suggestions. And I put my email in the chat as well. So feel free to communicate with me any ideas you have or insight. Oh, somebody else is saying something. Oh, the recordings, these programs are recorded and we put them on the kcqvic.org website, kcqvic.org website, and it'll take a few days, but you can always see this one and past programs on that website. Thank you, Stacy, for dropping that in the chat. All right, everyone, you have a great afternoon. Go Chiefs.